Good morning, everyone. So, tuberculosis is a common global burden amongst infectious disease. India accounts for 27% of tuberculosis cases across the globe, and UP is a highly TB-prone belt in North India with highest contribution of 21.58% cases in India. Prevalence rate in India is 312 and 427 in UP per thousand population. It occurs secondary to exposure to Mycobacterium tuberculosis due to direct infection or an immunological response. It is devastating and potentially blinding condition if the patient is ignorant to the initial symptoms. So timely intervention and adequate treatment are of utmost importance. In all cases, ocular TB is treated as active TB disease. So here we evaluated clinical profile management and outcomes of ocular tuberculosis. This was a retrospective observational study where we studied records of patients who were started on ATT based on presumed ocular tuberculosis from August 2021 to April 2023. We evaluated 2 to 7 eyes of 163 patients with ocular TB who were initiated on ATT, and unilateral cases were in 99 patients and bilateral were in 64 cases, and in majority of the cases were present in female in either unilateral or bilateral. The mean age of presentation is 36.8 years, and initial best corrected visual acuity was 20 by 125, that is logMAR 0.8 during presentation. The most common ocular manifestation was intermediate uveitis followed by panuveitis, retinal vasculitis and multifocal choroiditis. And amongst other associated findings, we have complicated cataract followed by vitreous hemorrhage and CME. Complicated cataract and CME was most common in panuveitis, whereas vitreous hemorrhage was most common in retinal vasculitis. This slide shows an array of varied clinical ocular manifestations in ocular tuberculosis. Same goes on here as well. And here also we can see some cases of untreated retinal vasculitis going into TRD. And in picture number 1, we can see occlusive retinal vasculopathy with CME. And in the third picture, we can see skip vasculitis. Amongst adjuvant treatment, oral steroids was started in almost 98.15% of the patients, followed by PST was given in 11.14% of the patients, and PRP was done in 6.13% of the patients. So out of 163 cases who were started on treatment, 104 cases, that is 128 eyes completed the treatment, and 59 cases, that is 99 eyes, were lost to follow-up. And out of the resolution status, 97.65% of the cases had complete resolution, and 2.35% of the cases were not resolved because of non-compliance to drugs. And the post-treatment best corrected visual acuity was in between 2030 to 2040, logMAR 0.26. And in the post-treatment sequelae, the most common was complicated cataract followed by ERM formation and cystoid macular edema. And in one case, we have after multifocal choroiditis resolution, we had CNVM, which was treated with Avastin injection. And in the last OCT, we can see the post-injection condition of this patient, and that amongst the treatment-related complications, secondary glaucoma was most common, and majority of which resolved by medical treatment only. And amongst the side effects of ATT, headache was most common, and on long-term follow-up, recurrences was most commonly seen in multifocal in choroidal granuloma, followed by multifocal choroiditis and serpiginous choroiditis. In another study by L. Ganvan et al., there they found the most common clinical presentation was non-granulomatous anterior uveitis, and the age of presentation was between 41 to 60 years, which was in contrast to our study where we had the mean age of presentation was 36.8 years, and the most common presentation was intermediate uveitis, which is also in contrast to another study by Sultana et al., where retinal vasculitis was most common, and we had recurrence rate in multifocal choroiditis and serpiginous choroiditis. And similarly, post-ATT course, none of the patients showed any ophthalmic manifestations like ethambutol toxicity, color blindness, and most adverse drug reactions were CNS related, similar to the other results studied as showed by other studies. Till date, very few literature exists with detailed comparative analysis of clinical TB, and so proper patient compliance for drug and long-term follow-up and public awareness regarding ocular TB course and consequences of delaying treatment can prove to be highly beneficial in the long run. Thank you.
How many patients in your study presented with a CNVM? Did anybody present with CNVM?
Sir, later on, after treatment, only one patient had CNVM. And
Was it active?
yes, sir.
And what was the, and how did you treat that again?
It was treated with intravitreal Avastin injection.
Avastin.
Yes,
Right.
sir.
Do you have any data showing any kind of improvement of CNVM with an ATT treatment?
No, it showed CNVM occurred after healing of the multifocal choroiditis, not during ATT initiation.
Oh, all right. Okay. All right.
So your topic was ocular tuberculosis.
Yes, sir.
So is there any case of that orbital tuberculosis or the tuberculosis of adnexa?
Sir, in our institute, we didn't come across such patient which presented with adnexal tuberculosis.
I think it's a good paper. You should publish this, but with that tuberculous uveitis, I think that please don't use the word ocular tuberculosis because ocular tuberculosis is a very vast word. And one reference that should be there will be an article, that landmark article by Professor Amod Gupta sir, published in Survey of Ophthalmology 2007. I think it is easily available. I think you should go ahead with that. Now coming back to your that paper. So in how many patients of that tuberculous posterior uveitis, means tuberculous choroiditis, in how many patients you have seen a solitary granuloma? How many patients you were having that miliary tuberculosis type of picture?
Miliary tuberculosis on
Yeah,
thorax.
because you have mentioned that clinical profile and management. So I just want to know that how many patients were there,
Sir, we have only evaluated the.
and what was the commonest presentation of that tuberculous uveitis?
The most commonest presentation was intermediate uveitis only, followed by multifocal choroiditis and choroidal granuloma.
And what were your treatment protocol based on which? How you decided that you will go ahead with this ATT?
Yes, sir. So we asked the patient to test for MANTU and X-ray chest or thorax in IGRA, and also we ruled out sarcoidosis.
I think IGRA is not very much reliable because I think that ICMR has banned all the serological tests for tuberculosis in 2011, I think, if I'm not wrong. I think that now we are having the recommendations of COTS 1 and COTS 2. So I think that our treatment protocol should be based on that COTS 1 and COTS 2 recommendation.
TB go.
Okay, it's a good one. It's a very nicely documented.